الثالث لمؤتمرنا. احنا سعداء ان هيبقى في برنامج علمي لليوم الثالث على التوالي، بس بيثبت ازاي ان احنا عندنا احباب كتير، والدكتوره سناء دايما بتحب ان احنا نركز في العلم بتاعنا على النقاط اللي تهم الناس كلها. وعشان كده جلسه النهارده الافتتاحيه هيبقى فيها الحقيقه متحدثين كتير عظماء، وهيبقى فيها مواضيع كتير قوي تهمنا عن الجات هيلث. واول متحدث لينا هنرحب بالاستاذ الدكتور علي المهيدب. دكتور علي المهيدب استشاري ورئيس اليونت بتاعه البيدياتريك جاستروانترولوجي هيباتولوجي اند كلينيكال نيوتريشن والمناظير في كينج فيصل سبيشاليزد هوسبيتال اند ريسيرش سنتر سعودي عربيا. ضيف عزيز واخ كريم وصاحب بيت، مش ضيف بس. دكتور علي هيكلمنا على ميك اوفر ا سكسسفول ستوري. هنستأذنه يتفضل للمنصه.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. صباح الخير. يسعدني أن أكون معكم في هذا اليوم المبارك، وأشكر الدكتورة زينب وباقي الزملاء، الدكتورة سناء وباقي الزملاء، هذه الدعوة الكريمة. الدكتورة زينب طلبت مني أن أقدم حالة of interest، وهذه الحالة مرت علينا قبل سنة، وكانت حقيقة حالة يعني it was a puzzle, and you will go through it and you can recognize the effect of nutrition in our daily practice. So I have chosen this title, Makeover. So how could you change people, how people look with something, it is very simple if you recognize it. I will go with the first slide. This is the patient before. She was referred to our clinic from our colleagues in dermatology. As you could see, she has severe cheilitis, crackled lips, swelling, as well as dryness, erythema of the hand, and the knuckle pads have thick pads of skin over joints. And this has affected the morale of this patient. And this is the patient after. So this is a big difference if you could recognize it. And to some extent, this is her hands. So what was done for this patient? I know most of us are not good in dermatology when it comes to dermatology, but this patient presented at 6 years of age to the dermatology clinic at King Faisal Specialist Hospital and Research Center with recurrent blisters, skin peeling, and severe pruritus leading to bleeding sometimes. And this had started at the age of 6 months. So she was suffering for 6 years, and she was seen by dermatology. And this is her presentation. You could recognize maybe the erythema, the knuckle pads. And also this is very interesting. We listened yesterday to Dr. Jalila when she presented about iron deficiency anemia, and she mentioned that we don't want to see colonekia because this is an advanced stage of iron deficiency anemia, severe iron deficiency anemia. So we need to act before the patient reach this stage. So this patient has colonekia also. And this is also, as you could see, same thing, peeling of skin. This is a scratch mark. She was scratching herself until she bleeds. and she has these knuckle pads also over her toes. And the mouth, she has severe cheilitis. She has difficulty eating. And for 4 years, she was followed in dermatology clinic, and she was thought to have epidermolysis bullosa simplex versus pityriasis rubra-pilaris. And the second diagnosis was based on a skin biopsy, which was interpreted by somebody else in the local hospital. However, whatever treatment was used for this girl did not work. They have used topical treatment, including emollients, lactic acid, Vaseline, QV cream, even cortisone cream, antibiotics ointment, tacrolimus, which is a calcineurin inhibitor ointment, and Duropin ointment. All did not work for years. And she received oral retinoic acid derivative, which is acitretin, and this did not make any difference. Because of the dryness of her eyes, they have used eye drops, and even the dermatologist, they used ultra B irradiation, and it did not work. So she has no response for 4 years to all of these management. And in follow-up, one of the dermatologists decided to check her vitamin A, because she was receiving this retinol derivative. So he was thinking of toxicity, and surprisingly it was very low. It was 143 with a normal range from 300 to 800. So despite the supplements of vitamin A, they were looking for toxicity. The vitamin A is extremely low. So they sent her to our clinic when she was 10 years of age, with a blistering skin disease, keratoderma, keratotic papules were found to have persistently low level of vitamin A despite vitamin A treatment. And they were thinking of malabsorption. So she was seen in the gastroenterology clinic, and she has a negative history of GI symptoms, including pain, vomiting, diarrhea, steatorrhea. She has no jaundice, easy bruising, bleeding. She has no joint pain, oral ulcers or alopecia, and there is no recurrent infection. She was in regular diet, no restriction to her diet, and she has no previous surgeries. And she was developmentally normal. However, socially she was withdrawn. She has poor school performance. She was not attending school regularly because the way she looks in school. And her family history is positive for consanguineous parents, and she has a younger sister who has the same disease. And she is a shy girl. She has poor eye contact. She does not look at your eyes when you talk to her. She's not pale or jaundiced, and she's not dysmorphic, and her growth surprisingly was on the 25th to 50th centile for both height and weight. So whatever malabsorption is there, she is maintaining good growth curve. And this is a summary of her: cheilitis, peeling of skin, these knuckle pads, and a remarkable physical examination, including eye exam, which was done by an ophthalmologist. So this is a puzzle. So this is a 10-year-old girl with dermatological features only. She has positive family history and low vitamin A level. So what was our differential diagnosis at that time? We thought of malabsorption. First, we thought of restricted intake, which is not the story. And malabsorption, including celiac disease, pancreatic insufficiency, or if she has a chronic liver disease, or does she have immune deficiency like Job syndrome or others? And lastly, whether she has a primary dermatological disease. So we don't know. So we proceeded to our investigation, and surprisingly, most of the investigations are normal. She has a normal complete blood count, normal renal function, liver function, and slightly elevated INR, which may indicate some vitamin D, vitamin K deficiency, and her bone profile even is normal, and she had a normal inflammatory markers. We did the fat-soluble vitamins, and both A, D, and K are low, and E is normal. We did, micronutrient levels, including zinc, selenium, and even copper, and all are normal. And, her lipid profile showed a normal cholesterol. Her triglyceride is low, although the retinol derivative increase usually triglyceride. This is one of the side effects. So she had persistently low triglyceride. And we did bile acids, and they were okay. Hormonal profile, including thyroid function test, parathyroid hormone testing is normal. Sweat test for cystic fibrosis is normal. Celiac profile, endomysial antibodies and the transglutaminase antibodies was normal. She had normal fecal fat, so she is not malabsorbic. There is no cytouria. Her pelvic X-ray showed generalized osteopenia, and what we did, we just went for endoscopy, and endoscopy was normal. We took multiple biopsies from the duodenum, stomach, esophagus, and all came to be normal. And we did our GI panel. This is a genetic testing where they collected more than 50 diseases affecting the gut, and usually we send this panel to our lab, and it came to be negative. So what would you be your next step? Any suggestion? صح. Family history is positive, so she and her sister have the disease or have the presentation. This most likely is genetic. However, it may be environmental, some deficiencies in diet or whatever, So what can we do? The dermatologist has, thrown this patient to our surface, and they said, we don't know what to do. This patient has low vitamin A, and you need to give us the answer. Even we are giving vitamin A, she does not respond. So what we did, we took our experience with patient with A-beta lipoproteinemia. We have a few families who have A-beta lipoproteinemia, and they have severe vitamin E deficiency, not responding to oral supplements, and we used to give them something called phytolipid, and periodically, and they respond very well. So we suggested to give this child the phytolipid and see. So we infused phytolipid, which contains daily requirement of fat-soluble vitamins A, D, E, K, and it contains lipofundin, MCT, LCT, 20%. So it is 50% soybean oil and 50% MCT oil with some LCT, the essential fatty acids, which contains linoleic acid and alpha linolenic acid. And let us see what happened. Second day after infusion, itching disappeared. Fifth day, we started to see oily hair. And 10th day, cheilitis decreased and erythema decreased. So there is a response. So is she having malabsorption? We are not sure. So the treatment response after first cycle is shown by figures. You can appreciate the difference before and after the treatment after first cycle. We gave 10 days of phytolipid infusion on a daily basis. As you could see, these skin peeling almost disappeared, and these knuckles have improved and became softer, as well as the skin peeling over the hands. Also the legs, you see changes. And this is her cheilitis. After the first cycle, see the difference. So this is first cycle. So we decided to give her a monthly cycle. So she was admitted to the hospital for 10 days every month to receive the cycles. This is the child when she presented to us. Very depressed. She does not look to anybody. You talk to her, she does not respond to you. Look at her hair. You know, for a girl who is 11, 10 years or 11 years of age, this is not the right picture that she would show, you know, people. And you see the treatment response after 4 cycles, which is 4 months. This is before and this is after. And this is before and this is after. There is a dramatic change. No more itching. Same. And look at her. She is completely different. You know, look, this hair is natural. This is after treatment. So it's dark black now. Look at her eyes. She can talk to you. She was going to school, and her mouth has almost, you know, healed. Her mentality, her psychology has changed. So what do you think we are dealing with? Is it a malabsorption or something else? So always when we have a dilemma, we go and dig in the literature and look for, you know, similar presentation of such cases. So we sent the fatty acid profile, and surprisingly, the alpha linolenic acid was extremely low. This is after the second cycle. So we gave her 2 cycles, and the arachidonic acid was also low. So this may explain what does she have. So she have low vitamin A, vitamin D, vitamin K, and she has low alpha linolenic acid and arachidonic acid. And by the way, we don't do this in our lab. We have sent this to Mayo Clinic, and it took some time to get the result back. And we did whole gene sequencing on this child. This is our trend now. If we have a dilemma in any patient, especially as Dr. mentioned, there is a genetic, you know, possible genetic disease, we have sent, you know, genetic testing. And because this is not in our GI panel, this is not a GI disease essential. And she was positive for this gene called CAST. They have the phenotype, peeling of skin with leukonychia, acral punctate keratosis, cheilitis, and knuckle pads, which is an autosomal recessive disease. And this fits in our child. So she has all of this. And what was reported in the literature before, in 2015, Zhao have, you know, shown that this gene mutation can cause peeling skin, leukonychia, acral punctate keratosis, cheilitis, and knuckle pads. And this was reported. In the literature, only 4 families have been reported, and 1 from Tunisia, which is close to Egypt. So you may have such patients in your country, here in Egypt, and 1 from Turkey, and others from Nepal and from China. So this is the disease which caused this presentation. And if you go in the old days, in 1929, this guy, Barr et al., he has shown that, you know, when you deprived rats from fat in their diet, on the right side of the screen, this is a normal tail, and this is abnormal tail of a rat who was deprived from fat in their diet. And this cause, you know, thickening of the tail, and this is applicable to, you know, the thickening of the skin in these patients. And we have reported this case, which is called plaque syndrome, is potentially treatable with intralipids. You know, in the past, all these cases were just descriptive cases, and this is the first time patient will respond to potential treatment. The plaque syndrome constitute, pruritus, peeling skin. For P, L, leukoplakia, A, acral punctate keratosis, C is cheilitis, and K is knuckle pads. And this is the first time we have proven that this disease exists in our area, and this disease can respond to intralipid. And this patient nowadays, she used to have intralipid every 3 months, and we have spaced it now every 6 months, and she is doing very well since then. I will stop here. I hope this case was just illustrative, and thank you very much.
Thank you, Dr. Ali, for a very interesting case. الحقيقة, thank you إن you shared the publication with us. I'm sure everybody here is interested. We are to read further about it. وزي ما دكتور علي نصحنا إن احنا تبقى في بالنا وندور عليها. A very good start للسيشن بتاعتنا. شكرا دكتور علي. واحنا نستأذن حضراتكم هنكمل السيشن ونخلي الأسئلة للنهاية.